welcome back. Hello, bienvenue, and welcome to another episode of Oncology for the Inquisitive Mind. I've been watching the World Cup, so that's where the French slipped in there. Today, we are talking about, I was expecting a reaction from Josh, my unusually, uncharacteristically silent co-host, who...
You were talking about sport.
That's true. I've completely lost Josh.
Except England lost to Argentina. I know that much.
Yes, well done. You have kept abreast of recent events.
Well, they were winning, you see, 1-0, and now they went down 2-1. So that's all I can tell you.
That's enough, Josh. I'm so proud of you.
Thank you. I was running this morning and I went to a coffee shop, and at the coffee shop, they've got the soccer playing, and it's like this group of lads. They're like all 20 and they're like, yeah. I'm like, I would love to be up at 3:30 in the morning to watch this and still function.
Ah, the joys. Yes, the olden days, far behind both of us. What's not behind both of us, what's ahead of us, is another jam-packed episode, and we are talking about hepatocellular carcinoma. Another one of our, what Josh described last week as orphan cancers, unfortunately quite common cancer with limited treatment options. And just like last week, we're going to have an early phase study and a metastatic or advanced disease study, but we're flipping the script because we like to keep you, our dear listeners and viewers, on your toes. So Josh is going to be taking it away with the early phase study IMbrave 050.
Yes, I'm brave going first, Michael. Let's talk about IMbrave. So hepatocellular carcinoma represents 80% of primary liver cancers. It's the fourth leading cause of death worldwide, and most arise from Asia, and over half of these occur in China. I suspect because of the distribution of the population more than anything. It's usually from hepatitis B and C, non-alcoholic steatohepatitis, or whatever the new term is they use, alcohol, and diabetes. Although, in saying that, non-viral causes are becoming much more common. Post-operative recurrence following resection or ablation exceeds 70% within 5 years, even if a candidate is lucky, has curative intent treatment. I said lucrative intent treatment, but I think I meant curative. The highest recurrences in the... I know.
I have so many jokes, and none of them are appropriate for an educational podcast.
Look, it is quite a tough cancer. So while I laugh at my own,
yes, we will laugh at Josh. We will not laugh at the subject matter.
That's the healthy part of this. The highest recurrence is in the first 2 years of either a resection or ablation, and is usually due to micrometastases of that primary tumour. The late recurrences are due to de novo tumours and underlying liver disease. So it sounds like that microenvironment is primed to have recurrences despite curative treatment. There have been other studies that have tried to weather this disease, the first being that of the STORM trial, which looked at adjuvant sorafenib versus placebo. Unfortunately, it did not improve recurrence-free survival. And there was also the phase 3 PATRON trial, which was adjuvant mipirfostat, which is a heparinase inhibitor, and also did not improve disease-free survival versus placebo. This is a tough cancer to treat. But then comes immunotherapy, and there was some interesting data in the adoptive immunotherapy, which had potential, but there was no phase 3 trial. And so this is where IMbrave 050 comes in. But I wanted to actually bring up the study design, because otherwise, no one has any idea what I'm talking about. So it's patients that have hepatocellular carcinoma that have been diagnosed, that have undergone either a resection or an ablation. They were disease-free with Child-Pugh A disease, and they had a high risk of recurrence. There was no extrahepatic spread or macrovascular invasion, and they had a good performance status. They were then randomized after surgery or resection between 4 and 12 weeks to either atezolizumab plus bevacizumab versus active surveillance alone. And they were continued on for 17 cycles or 12 months. And they were followed up for recurrence-free survival as that primary endpoint. The secondary objectives, which are also important, overall survival, time to recurrence, time to extrahepatic spread or macrovascular invasion, safety, and sustained efficacy measures. But Michael, I did a similar thing to what I did last time, and I'm giving you all the take-home messages straight away. But before I say that, for those listening on our podcast, let's talk about the methods. It was a phase 3 randomized global open label multi-center trial, including lots and lots of patients, or 668 patients. When you look at the take-home message, it was the first study ever to show that to improve recurrence-free survival in hepatocellular carcinoma. And while that is an exciting comment to say, the longer-term follow-up was disappointing. There are lots of reasons for that, and it might be the challenge of the crossover. It might be the medical autopsy that you have to do to try and figure out exactly why this has happened, or maybe it's toxicity. It's difficult to say. As of the latest follow-up data, overall survival is still immature. I've just included the design methodology, and you can see about 300 odd patients have been randomized to both arms. With the first follow-up, which is about 17.4 months, we actually found significant improvement. So there was a 28% reduction in the risk of recurrence or death with a hazard ratio of 0.72. Booyah, we've got something. Let's hold on to that tight. The 12-month recurrence-free survival was 78 versus 65% in the surveillance arm. So also really, really exciting. But let's talk about the updated analysis with a median follow-up of about 35 months, or just under 3 years for people with small brains like myself. The median recurrence-free survival was 33 months in the atezo arm, plus bevacizumab. Sorry, bevacizumab, didn't want to forget you, versus 36 months in the active surveillance. It's diluted, Michael. This is a difficult point, right? Because it's gone from what has been really reassuring to actually 0.90 and losing a statistical superiority. So while we saw an early follow-up and improvement, not a long-term follow-up improvement. And so there's so many questions. It's a good trial to talk about data, really, and overall survival. We've got another slide, which is immature, and why I think this might have happened. So the crossover conundrum. The first being that 30% of patients crossed over, or 99 individuals. The second point I wanted to talk about is toxicity. Difficult because it's versus surveillance, right? So you'd really hope that the intervention arm had a bit more tox than surveillance. Otherwise, there is something else going on with this study. But 98% versus 62%, that's most trials, right? Treatment-related adverse events about 36 versus 14%, and discontinuation, you saw about 46% of patients in the intervention arm had a treatment break, and about 20% of those patients ceased treatment early due to toxicity. And so that is something to really think about. And so while the final verdict is early outcomes show that this does improve recurrence-free survival, it wasn't sustained, whether that's crossover, whether that's toxicity, whether that's we only had 1 year of therapy. These are 3 really big questions to sort of ask. And I think we have to learn about accepting data early in certain, essentially hard to treat cancers, to be like, well, maybe, just maybe we need to wait a little bit longer. I don't know if this actually is not an effective drug, meaning I think it potentially does work. I think the design and the study itself faltered and might have led to this being the outcome.
It's really interesting, isn't it? Because yes, you talk about crossover and what have you, but with recurrence-free survival, you would anticipate that would be slightly protected from crossover, perhaps, because the endpoint is the disease recurrence, at which point they would get the atezo bed. Overall survival is obviously different. But I think your point about the treatment duration is an interesting one, because the only other, I was racking my brains when I was looking at these Kaplan-Meier curves for a similar example. And the only other example I can think of is, from memory, it's the Flora or the ADORA study, where one of the criticisms of the adjuvant osimertinib was that there was a noticeable drop-off in patients and the number of patients at risk in the osimertinib arm after the adjuvant therapy finished. And so whether the question that was raised from that is whether they need, I think it was 3 years instead of 2 or something of that nature. And I wonder if it's a similar thing here, because that is quite a noticeable shift in the fortunes of atezo-bev in this space.
And look, yes, maybe recurrence-free survival should be protected, but with a disease like this, the actual question you have to ask is, do we ever truly get rid of it? Or is it kind of a control mechanism for a cancer like this? That's what I was trying to refer to.
In which case, the duration question comes in because, even though it's an adjuvant, as you say, curative intent study, are we still effectively only treating these patients with palliative intent? And so do we need to extend the duration?
Exactly. Well, Michael, we didn't climb that hill. We didn't get up that mountain, but I think the Himalaya is our next target. Why don't we jump tact a little bit?
We're nothing if not ambitious, because we're going from running up that hill to the Himalayas. So HCC, as Josh very kindly and eloquently said, is one of the most...
Stop it.
One of the most common cancers.
I want more compliments. Say something else nice.
That's all you're getting, Josh. I'm weaning you off compliments. This has been part of your intervention. HCC is one of the most common cancers globally. There is a significant proportion of patients in Southeast Asia, China, areas that are quite endemic with hepatitis, although, as Josh also said, that is shifting towards a more metabolic picture. And atezolizumab and bevacizumab, contrary to their sort of mixed results in the adjuvant setting, was the first to show an improvement over sorafenib in the advanced unresectable setting. And I've got here the results from the updated IMbrave 150, that's the advanced study, which shows a significant, both clinically and statistically, benefit of atezolizumab and bevacizumab over sorafenib. For those of you listening, the median overall survival at the updated analysis was 19 months compared to 13.5 months for atezo-bev and sorafenib, respectively, hazard ratio of 0.66, and of course that was statistically significant. PFS was terrible, let's not beat around the bush here, but better with atezo-bev, 7 versus 4.3 months. Again, hazard ratio of 0.65. Similar rates of grade 3 to 4 adverse events because sorafenib as a multi-kinase, multiple TKI is a fairly, as what we would call, dirty drug. And there were 6 grade 5 events throughout the trial. So that is the competition against Himalaya. But there are patients for whom the combination of atezolizumab and bevacizumab is not appropriate. One of the major comorbidities or concomitant conditions with hepatocellular carcinoma is obviously cirrhosis of one kind or another, which can lead to portal hypertension, which can lead to gastroesophageal varices. And if you have a bleed from a varix, I think that's a singular term, from a varix, and you're on bevacizumab, you are at an incredible risk of mortality and morbidity. Bevacizumab is also a prothrombotic agent, so you're at an increased risk of venous thromboemboli. And so if you have patients who are vascular paths, you really don't want to give bevacizumab, and there's not any data that I'm aware of for atezolizumab alone. So this is where the Himalaya regimen or the STRIDE regimen comes in. Now, STRIDE stands for single tremelimumab regular interval durvalumab. One of those acronyms that I think someone started with STRIDE and tried to figure out how to fit the tremelimumab and durvalumab into it. But it is exactly what it says. It's a single dose of tremelimumab followed by regular durvalumab. And the Himalaya study was the study of this combination in CTLA-4 PD-1 in comparison to sorafenib. There was previous phase 2 data that demonstrated that it had some benefit for those who had already progressed after sorafenib, but this was the head-to-head comparison that we were all looking for. Now, the eligibility criteria for this study are pretty standard. So you had to have untreated hepatocellular carcinoma, so you could not have had atezo-bev or sorafenib, obviously. You could only get on if you had Child-Pugh disease, and you had to have a Barcelona Clinic liver cancer stage of B or C. And I've put that up here for those of you who are watching on YouTube. It's these sorts of patients who have this multinodular HCC that is unresectable. They might have sort of portal invasion and various other sort of anatomical and imaging characteristics that would class them as that. And this is where systemic therapy has traditionally lived. They also had to have an ECOG performance status of 0 to 1. Inclusion criteria, I think they're important for these sorts of studies because these are the sorts of patients that you do commonly see in the clinical picture. So patients with clinically meaningful ascites, portal vein thromboses, or co-infection with hepatitis B and hepatitis C. Now, the consort diagram does show, for those of you watching, 4 treatment arms. And originally, this was how it was set out. There were 4 treatment arms in the HIMALAYA study. The 4 arms were the STRIDE regimen, which is 300 milligrams of tremelimumab, which is a CTLA-4, only once, followed by 1,500 of the durva every 4 weeks, durvalumab alone, and sorafenib. Sorafenib is the comparator. The 4th arm was a regimen of tremelimumab 75 milligrams every 4 weeks for 4 cycles with durvalumab, which has been labelled T75 plus D. Similar, I guess, in construction to Ipi-Nivo, where you have the 4 cycles of the combination and then the PD-1, PD-L1 by itself. But this was found not to have a significantly improved efficacy compared to the STRIDE regimen. And so this arm was closed early. So patients, as a result, were randomized 1:1:1 to those 3 arms, as mentioned before, and the stratification factors were macrovascular invasion, the etiology of liver disease, whether it was hepatitis B or C viral cirrhosis or other, metabolic would be the other one, and their ECOG performance status of 0 to 1. The treatment continued until progression, toxicity, or consent withdrawal. And patients could continue treatment after progression if the investigator assessed that they were benefiting from treatment, which is always important to say because it does inform clinical practice, but also sort of colours some of the results. The endpoints were the overall survival for the STRIDE versus sorafenib. So again, 3-phase study. The 2 immunotherapy arms are not compared, which is annoying. But I think we're sort of used to that by now. But that was the primary endpoint. The secondary endpoint was the non-inferiority and superiority for overall survival for durvalumab alone compared to sorafenib. The overall survival at 18, 24, and 36 months, progression-free survival, time to progression, overall response rate, disease control rate, duration of response, and patient-reported outcomes. All of that good stuff. So in terms of the demographic notes, I just always like to put these in there. So 80% of patients had Barcelona liver cancer stage C, so the more severe one. 41% had non-viral HCC. More than 50% had extrahepatic spread, presumably to either lymph nodes or lungs. Those are the most common sites of extrahepatic progression. And less than 40 patients were PD-L1 positive, which is defined as a TPS of greater than 1%. So already you're thinking, well, the immunotherapy might be up against it. So after treatment discontinuation, after progression, 40% in the STRIDE arm and 43% in the durvalumab arm and 45% in the sorafenib arm received second-line anti-cancer therapy. And we mentioned how patients could continue after progression. Almost half of patients in the 2 immunotherapy arms and about a third in the sorafenib arm did continue treatment beyond progression for at least 1 cycle. But as I've had this slide up for a while now, for those of you watching, the primary endpoint of the median overall survival, which is STRIDE versus sorafenib, was met. Was it clinically significant? I mean, that is always the question with these things, but it was 16.4 months compared to 13.7 months with a hazard ratio of 0.78, which is a statistically significant. But again, as you can see from those Kaplan-Meier curves, as Josh likes to say, you couldn't drive a truck between the curves. The survival rates at 18 months, 24 months, and 36 months were higher. And similar to what Josh was talking about last week with Topaz 1, you did see a widening of the interval. So for comparison, at 18 months, the difference between STRIDE and sorafenib in terms of overall survival was 48 compared to 41%. However, that interval had widened at 36 months, where the overall survival for STRIDE was 30% compared to 20% for sorafenib. So you can see that there is that widening as well. Now, in terms of the key secondary endpoint, which, as you remember, is the non-inferiority and superiority of single-agent durvalumab against sorafenib, durvalumab was found to be non-inferior to sorafenib, but it was not superior. It was not statistically significantly superior, with a p-value of 0.06. So durvalumab can be exchanged with sorafenib, but it's not a better option. In terms of other secondary endpoints for STRIDE versus sorafenib, the PFS hazard ratio, interestingly, was not statistically significant. It was 0.9 with the STRIDE compared to the sorafenib, and 1.2 with the durvalumab compared to sorafenib. However, we should say that, this is something that we have noted in immunotherapy trials before, where the PFS is similar, but the overall survival is not significantly, or the overall survival is significantly better, I should say. The overall response rate was highest in the STRIDE arm, much higher than the sorafenib arm, and the patient-reported outcomes were similar between STRIDE and durvalumab, and both were superior to sorafenib. So you are getting a quality of life improvement. Now, in terms of safety, because I have heard tremelimumab described as ipilimumab's psychotic cousin, so it is associated with significant toxicity. But interestingly, the rates of grade 3 to 4 treatment-related adverse events were actually highest in the sorafenib arm, 36% compared to 25% in the STRIDE arm, and then 12% in the durvalumab arm. There were 9 grade 5 treatment-related adverse events, 6 of which were immune-related, and I'm pretty sure these all happened in the STRIDE arm. So there was myasthenia gravis, nervous system disorder, myocarditis, acute respiratory distress syndrome, pneumonitis, hepatic failure, hepatitis, and immune-mediated hepatitis. So it is, a reminder that these treatments are not benign, particularly when you're combining a CTLA-4 with a PD-1. However, there is this option, I think, Josh, for using STRIDE in the place of atezo-bev if there are complications. I did speak to one of my colleagues at the hospital where I work and asked him, what do you use as a baseline? Because we have access to tremelimumab and durvalumab under the PBS, I believe. And he said still the reflex is atezo-bev through IMbrave 150, and numerically atezo-bev is better, but you do have those patients for whom that's not appropriate, and HIMALAYA is an option that you could use.
Yeah, I think my time of treating these cancers is, apart from when I cover or if I'm working regionally, you don't see it that often unless you're a large volume center. But I found atezo-bev generally, fatigue was one of those side effects, but overall not pretty well tolerated. That was just my clinical experience. Might have been the demographics I was dealing with, but I don't know, just that was my thing. But look, it's another option, and I think options are good. Options are like the 400 cholesterol tablets you can have. You might not agree to one, but you all agree to the other.
Exactly. And with the immunotherapy permissions and authorizations loosening up quite significantly in Australia, it is an exciting time.
That's it. Well, options are nice.
Options.
Yeah, exactly. Well, Michael, that brings this episode to a close, but what are we going to do next week?
So we've spent a lot of time in the alimentary tract with gastric and esophageal and colorectal and now hepatobiliary, but we're putting that behind us and we're going to a cancer that affects the largest organ in the body. And if you know your pub trivia, you will know that is the skin.
Michael's brain. What?
You're very kind, Josh. I see you are not weaning me off my compliment sandwich.
No, that's what I do.
So we're going to be talking for the next few episodes about skin cancer. We'll be starting with non-melanoma to skin cancer before diving into some of the interesting developments in melanoma. So we hope you join us for those sunny episodes.
Exactly. Bye, Michael.
Bye. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.